Hi, I'm Sharrie Harlin-Davis, program host for Reid Beside You. And today our guest is Dr. Mario Lee. And Dr. Mario Lee is with Reid Orthopedics. And also a fun fact is, and help me out, Dr. Lee, that you were one of the first employed physicians under Reid.
Yes, I was actually nice to be here. It's my second time around. Yes, I think I mentioned last time that I was the first Reid employed physician for Reid Hospital when it was Reid Hospital 12 years ago. So I came on in March of 2008.
And you're still here, and we're thankful for that.
Oh yeah, it's been a wonderful ride, as you can say, throughout the years. The hospital has really done well to take care of all of us and also the community.
Great. So today we're going to discuss joint replacement.
Yes. The reason I wanted to come on and just to give a little bit of feedback is because joint replacements, the way they're done, is being changed. The technology available these days is just putting us really at the forefront. And Reid Health has really committed to providing really excellent, outstanding health care. And so one of the ways we've done is actually with the addition last year of the Mako robotic assisted technology to really help change the way that joint replacements are done these days.
So what's some of the common causes of joint pain?
So I think the most common causes of joint pain, certainly something arthritis is really the most common cause in the older population. Now that can be possible in the younger population, but given that the topic is so big, we'll focus more on the arthritis part.
Okay.
So arthritis in general, most patients would think of wear and tear arthritis. That's osteoarthritis, and that's the great majority of the cases. The analogy I like to give my patients is, you drive your car long enough, you go through enough potholes, you go stop signs and everything, is that your tires slowly wear out. Unfortunately, when your tires wear out, it's not like you could put rubber back on the tire. Eventually you have to talk about getting new tires. So that's the most common type, osteoarthritis.
I like that analogy.
Yeah, I think something most patients can really deal with. Now, a lot of patients always think, oh, what if my family has rheumatoid arthritis? Well, rheumatoid arthritis is really a completely different, where the body attacks itself. So a lot of the joints that you have in parts of the body gets destroyed at a much younger age. So that's why you even have patients with juvenile rheumatoid arthritis, where you can have devastating effects on the joints at a much younger age. So that's something they can always try to determine by seeing a rheumatology doctor who can do some blood works and do an exam and everything to ascertain if you really have rheumatoid arthritis. Now, there's also another subset. Okay. It's called post-traumatic arthritis, and that's by definition someone who's had an injury, hurts themselves like a broken bone, undergoes surgery, and then over the years will develop arthritis because it's after an injury. And because of that post-traumatic part, you'll see patients at a much younger age developing arthritis. I'll give you an example. I had some patients who, let's say at a younger age, they were doing a sports injury and they blew out their ACL. They had surgery, they'd done well for 20 years, but then they start having dull, achy pain going up and down stairs, bad weather comes on, kneeling down, it's very hard for them because they have to grab onto something to get up. So when you examine them and get x-rays, you see they have evidence of early arthritis changes. So the average age for a joint replacement surgery, someone who's never had surgery, is 67. But someone who's actually had ACL surgery, the average age of a joint replacement is 50. So you can see how some type of trauma to the extremity really causes them to develop arthritis at a much younger age. Absolutely.
So that's why we're seeing so many people needing, I know in our service area we have an older population that might need the joint replacement. And then you add in the people that are active as well as aging. So is that why you see so many people needing replacements?
Yes, and that's a really good point, because the demographics will tell you there's just been a huge inflow of the number of people who will require orthopedic services. I'll give you an example. 2018, they gave some data, and there are approximately 600,000 knee replacements being performed in the United States.
Wow.
Because you have the baby boomers, the another younger generations who've had injuries, the number of joint replacements for knees only by 2030 is going to jump up by 673%. You know, if you think about it, 700% almost increase in joint replacement surgeries. So the number of surgeries that is going to be required is just going to explode. And that's why it's so exciting to see the use of this new technology really changing the way patients recover and do well, that having this available really does help, because even now the number of replacements we're doing is just, it's pretty amazing how busy we are, but it's just going to get so much busy. Yeah.
Yes. So some non-surgical treatment options?
Yeah. Something you always want to discuss, something you want to at least try. Certainly from a medication standpoint, you can try Tylenol arthritis, Advil for some patients. And this is something that you can also discuss with your physicians, because some patients can't even tolerate it. So this is an ongoing discussion that you have throughout the years with your physician. So certainly Tylenol, arthritis, Advil, Aleve, some patients like. And there's some topical agents that you can also do, such as icy hot lotion or BioFreeze. Now, other patients can also try cortisone shots, which are steroid injections to help reduce the inflammation, and that can buy you some time. There are also lubricant shots that you can also try, and that kind of gives you a little temporary relief of your symptoms. Physical therapy is a very useful adjunct to try to maintain your motion, your quality of life, being able to move. Assistive walking devices, some patients will use a cane or walker to help them get around. Those are all things that you can try. I would say, though, that given the demographics, also another thing that you can really control is a patient's weight. Well, why is that? Well, the patient's weight is really critical, because when you walk, you actually put 4 times your body weight across your joints.
Wow.
So that means your lower back, your hips, and your knees. So simple mathematics. If you weighed 100 pounds, you're putting 400 pounds of pressure across your knees. So it's exponential. So let's say I gained 10 pounds. I may have gained only 10 pounds, but that means I'm putting 40 pounds more pressure on the knees. That's why I have patients who lose weight, that their knees feel better. It's amazing. So we also have programs available that we want to refer patients who are on the heavier side to make lifestyle changes. So we have clinics available for patients who are on the heavier side to help them in their lifestyle, to help them in general for their overall sense of health, but also for their joints, because a little bit of weight loss, really, it's amazing how much help you can.
Way.
Oh, amazing. You know, I've even had some dramatic changes where I've had some patients who had bariatric surgery, where they might have lost 100 pounds and all their joint pain goes away. Eventually, yes, things will wear out, but those 5-10 years that they can buy themselves, it makes a big difference for some patients. Oh, yeah.
Wow. So when do you consider?
I think I can encapsulate when you would consider. So I tell a lot of patients is that when you feel your quality of life is compromised. So from the patients who say, you know what, I can't even go to take a nice walk with my grandkids. I can't take a walk in the park because it's not enjoyable. By the time I get home, my knees or my hips, they're just aching. My motion is limited. I can't pick up my grandkids. I enjoy gardening. Impossible for me to kneel down. I have to hold on to something, and I feel like, you know, I need help getting up. Also, there are some patients who legitimately are scared that they may fall. So fall risk is a very big thing. So I think all those things can be encapsulated because their quality of life is really compromised and they can't enjoy the things that they do. So they know when they really come across that bridge, we're saying, you know what? I tried all conservative modalities. I've tried cortisone shots, weight loss. I occasionally use a cane. You know, I tried that biofreeze. I tried a cortisone shot. You know, it used to help me for 3-4 months, but you know, doc, it doesn't help me anymore. It only lasts 2 weeks. So what's my next step? So it's pretty obvious when patients feel like, you know what, I just don't enjoy life right now. I feel like it's really been a struggle. And by the time they reach that stage, they're really ready to go. So the only drawback to that is that we have so many patients are in that stage. We can only do so many surgeries a week, and so it's been crazy busy. But we always try to accommodate the family and the patients as much as we can.
Right. So you haven't brought some examples. So let's look at a hip.
Yeah. So when we talk about hip replacement, hip is essentially a ball and cup. So when you talk about osteoarthritis or any kind of arthritis, is that the ball and cup has really started to wear out. Okay. So anytime you move the ball within the cup, it really hurts to move the hip. So patients develop a lot of bone spurs. Mm-hmm. You have a grinding sensation where because the cartilage, which is just nice and smooth, it's all worn out. So now what they have is just bone grinding on bone. So anytime they move their hip, it's really been painful. So because of that, result is that they end up getting stiff. You also end up forming bone spurs, and people also can get a popping sensation. So when you do a hip replacement, you actually replace the cup part here, and then it's a metal cup, and with a metal plastic liner. And then on the femur side, or the ball side, you actually cut out the ball part and put in these artificial components.
Wow.
So old-time ways, yes, we've done thousands of these. We have extensive experience, everybody in our group. So we've done, and the patient's quality of life has really improved dramatically. Out of all the surgeries that we do, certainly joint replacement surgery is the most satisfying surgery because it really allows patients to regain their quality of life. So it's been a big difference. But now, as I'll touch on a little bit, the addition of the Mako robotic assisted, it really is changing the way joint replacement is done.
As well as, before we move on, we have an example of a knee.
Yeah, in the knee, we also talk about, because knees are clearly the most common form of arthritis, much more than even hip replacement, and also shoulder replacement surgery, because that takes the brunt of a lot of the wear and tear. Mm-hmm. So on the femur side, you have a knee that kind of just bends backwards and forwards. Over time, the cartilage will wear away, so anytime you move your knee, it's very painful because you have bone grinding on bone. And then your kneecap, which is under here, really helps you get up from a sitting position and get, so really going up and down stairs is going to be very painful. So when you talk about joint replacements for the knees, you look, is it in all three compartments? Because we talk about the inside compartment, the outside compartment underneath the kneecap. So the beauty of the knee replacement is that you can do either a partial knee replacement if the arthritis is just isolated in one part, or is it in all three compartments? So something you can determine with your physician. So when you replace it, you cut out just enough, you're talking around a little less than ½ an inch of the bone grinding on bone, both on the femur side, tibia side, and you lock in these components with these metal components and then a plastic liner in between. So that allows bone grinding on bone is cut out, and you replace it with these artificial components and really allows the knee to bend backwards and forwards without having bone grinding on bone. So that's why it provides so much pain relief. You take out the part that's grinding on each other and replace it with artificial components.
What are the percentages of partial knee versus a total knee replacement?
Certainly, the total knee replacement, because the majority of the patients who come and present after they've tried all conservative modalities, is that majority are full knee replacements.
Okay.
Now, there are some patients with very isolated arthritis, and they're on one side, and so you would consider a partial knee replacement. Certainly, activity level and demands is also a component that you would take into account when you discuss with your physician.
Now, this part I'm real excited about with the Mako.
Yes.
The robotic arm assisted, and how it assists you in surgery. I want to clarify. People see the robotic arm and they assume the doctor might be somewhere having coffee. When you're actually doing the surgery, it's the robotic arm just helps a lot. So.
Yeah, and that's really funny because a lot of patients do feel like I'm in the back playing the video game and then just controlling the robot. You know, the Mako robotic assisted technology, it's really amazing because it's changing the way joint replacements are done. I've done over 1,000 joint replacements myself, and this is without ever having the robot use. So extensive experience is very critical in having patients have good results. However, with the assistance of the robot and changing the way it's done, it's really taking it up a level. Because before surgery, you would get a planning with getting a 3D CT scan. And what that does, it actually visualizes the whole anatomy, because every patient is very individual and very different. Everybody's anatomy is very different. So we can plan and get a three-dimensional model of the patient's anatomy before surgery. So I know where I'm going to make my cuts, I can make the plan, and we can have the individual instruments be very personalized. So on the day of surgery, in surgery itself, we have markers that we can register and confirm the patient's anatomy. And then even before we start the surgery, we can adjust accordingly to make sure that everything in the knee is beautifully balanced. And even the resections, we're talking even 0.5 millimeter. So half of 1 millimeter is amazing. Like, I want to take 1 more millimeter off, I take the robot out, we reprogram the computer, I bring the robot in, and the leg, if it moves, the robot moves with me. But I guide the robot arm. So intraoperative, we can make adjustments until we feel very comfortable that this is a beautifully done surgery for the patients to really recover well. So intra-op, it's not like I'm in the back controlling it. I'm actually assisting the robotic arm, and it's amazing technology because if I move a little, robot moves with me. I bend the knee more, the robot adjusts accordingly. So the robot really makes for an amazingly beautiful knee. And having it be so precise, it does help patients with recovery. So, you know, last year, Reid Health was really committed to providing forefront technology and really providing outstanding health care for the community. And so when we presented this to them, they were very receptive to it, and they wanted to do what's best. So we undertook to purchase this, and it's really been amazing how this technology has changed. And so all of us are on board with it, all 4 of my partners. So we're all doing robotic assisted technology surgery. And then it's really exciting because we know that the explosion of more joints are coming. Mm-hmm. And then now that we have this technology and we have the support of leadership at Reid Health, it's been very nice to see patients do well. So, you know, the reason I got into orthopedics is because I want to give patients their quality of life back. It's very exciting when I can get a hug from a patient. They're just very thankful because they allowed me to be part of their lives to help them regain their function. And when they're appreciative, it really is very thankful. I'm very thankful for that process and to be part of it.
I've been firsthand. You've participated in some of our community education events, and it's been interesting when the audience members get so excited when you're going to be there because one person says he fixed my hip and another person said he fixed my knee or my shoulder. So
yeah, I'm very thankful.
Very excited.
Yeah, it's been this is my 12th year here, and a couple of my partners have been here longer too. So it's very nice to see that growth and that we can provide a service to the community that really helps them out.
And so when you're doing this surgery, what's the actual recovery? How does that work?
So even in recovery, we have a lot of those plans set up. So even going to a joint class before surgery to know what to expect, providing a joint book, having all their appointments, and even standardizing to make sure they're medically stable for surgery. In surgery, we go over everything again, and then a lot of times after surgery, they already know what to expect because we've gone over this in the joint class.
And I want to highlight that you have pre-surgery. You've talked to the people. You have looked at some of the risk or what can be better. So you've already pretty much a counseling session.
Yes, and I think having a better informed patient really helps their recovery. And so the majority of the patients actually even go home by the next day. It's amazing because when I was in residency 20 years ago, and that we would expect them to walk 250 feet and try to leave by day number 4 after surgery. So it's amazing that the recovery is faster. Patients do better if they can go home because they're in a more familiar environment. Majority of the patients do outpatient therapy. Some get home therapy, and there are some patients who, for some reason or another, may require going to a nursing home. So we tell them about the whole process and what to expect before, during, and after surgery.
So that way they're better prepared, and there's nothing worse than thinking you're going home and you're not. So that's all part of the counseling.
Absolutely.
Now, when you were saying 20 years ago, what was the average day?
Oh yeah, we would just be happy maybe walking a couple hundred feet and doing a couple steps and trying to go home by day number 4. We want patients to try to regain their motion, their strength and recovery in a safe manner. So yes, a majority of patients do go home and already therapy is already set up. They start with motion, healing of the wound, and then with therapy they try to move the process along. Initially they may be in a walker, then they transition over to a cane, and then we want them to get to the point where if they're occasionally sore, they're off any walking devices, they're moving, they're walking, driving the car, being able to take walks with their family or spouses, and slowly we increase their activity levels. So that's one aspect of it, but we also tell them the things to enjoy and things that they cannot do even after surgery.
That's what I was going to say. What are some of the limitations?
I think the main thing you can try to put them all together is things that are just high demand activities. So certainly rock climbing, skiing, things that are really hard on the joints, playing basketball. So those are things,
Maybe you
and
don't
even
want to
jogging.
jump on a trampoline so quickly.
Yeah, taking a nice walk even after dinner, even before surgery, and after surgery is always something because it maintains their activity level. So things like that, we want them to enjoy. Tennis is certainly within reason. Basketball may be out, but certainly rock climbing may be out, but swimming, taking a nice walk, a brisk walk, those are all things we want them to enjoy. Bicycling, those are all low impact exercises and sports that they can participate in. But the high impact one, we want them to avoid. Why? Because just as anything, even once you replace it with artificial components, in the middle you have this piece of plastic. Well, if you move your knees 10,000 times in a day, over time it will wear out. Now the average joint replacements last up to 17, 18 years. And these high-grade plastic, it's amazing. It wears out on average 0.1 of 1 millimeter a year. Think about it, a tenth of 1 millimeter. That's amazing if you think about 10,000 cycles in the knee and you're walking around. But technology has really pushed out at the forefront, and now we're just taking it up a level with the use of the Mako now.
Okay. Well, and if someone wants to get in touch with your office,
Absolutely.
you're at the Reid Orthopedic Center.
Yeah, they can certainly contact Reid Orthopedic Center, and we have 4 very good people. If they wanted to see me, certainly I'm more than happy and try to be available as much as I can. They can certainly contact our office. They don't always need a referral. A lot of times they can go directly and call us, or even on our website, Reid Orthopedic Center, or they even link through Reid Health.
Okay. Well, we want to thank Dr. Mario Lee for joining us today on Reid Beside You. And thank you for joining us on Reid Beside You.